and so that's where most of our work has been focused. And with that, I will pause and we'll take a...
Thank you. Thank you very much, Dr. Madrigal. We'll come back to you. Thank you for sharing your perspectives, the updates from a children's hospital, particularly those two cases, both in terms of how do you manage folks when they have less social support systems, and the second case where, in fact, the individual may be in a context and in a situation that they can be potentially harmful, and yet we have to protect them from further harm as well at the same time. So very interesting dilemmas. I want to move now to our second speaker, Dr. Katalin Roth. Dr. Roth is Director of the Division of Geriatrics and Preventive Medicine and Professor of Medicine at the George Washington University School of Medicine, as well as the GW Hospital. She's also a member of the Medical Faculty Associates. She's had extensive clinical experience and is now working not only on geriatric issues, but so hopefully, Dr. Roth, we'd love to hear a little bit from you about some of the clinical issues you're coming across or your colleagues are coming across. And I'm going to hand it over to you for an opening 9 to 10 minute statement. Over to you.
Okay, thank you. I really appreciate the opportunity to talk to you about the challenges that we're facing with COVID. Many of the things that Dr. Madrigal pointed out are issues for us as well. I do geriatrics and palliative medicine, and so advanced care planning is very important in this time of COVID. I wanted to talk a little bit about the challenges we had in the hospital about triage. We're not yet in an absolute scarcity situation, but I know you've all been following the news and know what happened in Italy, what's going on in New York. And so we had a little bit of time to prepare in the DC metro area for conditions of scarcity. And I want to talk to you a little bit about the policies that we've come up with to help our healthcare workers proceed in a condition of scarcity. And parallel processes have been, I don't know how to advance this, let's see. Yeah, have been going on all over, and these are not new. After Hurricane Katrina and the issues that happened with patients at Memorial Hospital, which I'm sure many of you are aware of, and during the SARS epidemic, people were talking very actively about the need to have guidance for a pandemic situation. And this slide just shows some of the resources that are out there. There are slightly different ethical frameworks. In the state of Maryland, they actually had a public process where citizens came in focus groups and talked about how to prioritize. So this is actually something that has been going on for a while and needed to be implemented. So I have two cases for you, and I hope I have a few minutes to come back to them after I go through my brief slides. One would be a pretty typical case, a nursing home resident, somebody who's very dependent in activities of daily living, has advanced dementia, has metastatic cancer as well, comes to the emergency room from the nursing home with fever and shortness of breath, and is presumed or found to be COVID positive. This person did not express advanced care or advanced directives when he was capable of doing so, and the family asked that everything be done. This is pretty typical situation before COVID. Somebody would come with pneumonia, urosepsis in this situation, and the family's request for full support, including intensive care support and ventilator support, would have been followed, although obviously we would try to explain to the family what that would mean for this person. Look at another patient who might come in, a 55-year-old fireman. He has risks for COVID, but he's also been working as a first responder. He comes to the emergency room with fever and shortness of breath, and the family and the patient himself request that everything be done. So what happens if we only have one ventilator? Or if we have 10 ventilators, but we know that people are coming into the ER every hour with similar presentations. How do we make decisions? So when we go back to our basic ethical precepts, I'm going to spin this a little differently. We talk about a duty to benefit patients, to help people, and to not do harm. But there are other corollaries that we don't usually talk about. We don't do what does not benefit a patient. Physicians are not obligated to provide care that is not beneficial. We're also obligated not to overtreat. We are obligated to try to avoid rationing if we possibly can, but we have to use temperance in our decision about what kind of treatments to provide. We treat everybody as having an equal moral claim to treatment, so we don't discriminate. This is based on whether resources can be properly used to help the most people. So in the era of COVID, it is absolutely imperative, as it always has been, that people have advanced care planning. And the best nursing home practices now include going around and talking to patients and families while they're in the nursing facility or the assisted living facility or the retirement facility. We're talking about high-risk elderly patients here, to make sure that people can express their preferences. I want to second what Dr. Madrigal said. We need to give people hope. We need to give compassionate conversations. We need to reassure patients. Most people do fine with COVID. Most people do recover. One thing we found is that when one person comes to the hospital, they often have ill family members. This has been a big issue in New York. So even if someone has an advance directive and they've designated a surrogate, that surrogate may also be too ill to speak with. We try not to be manipulative. In Colorado, the advance directive forms that have been used at the University Hospital on the COVID epidemic says, if we were in a situation where we had to make hard choices, would you want the ventilator to go to a younger person or someone in better health? Well, that's a rather manipulative or coercive thing to say. We don't ask that, but we do tell people that they need to make decisions. They need to think about it. And we also are telling our patients that we are not rationing right now, and we are doing everything in our power not to ration, but we are trying to find out what people's preferences are. So the new policies that we've put into effect allow us to make decisions about scarce resources like ventilators based on prognosis and based on the likelihood that somebody will benefit. And that includes maybe deciding not to do a resuscitation if a resuscitation would not help. We frequently, in non-COVID circumstances, have conditions where people are already getting pretty maximal support. They're in the intensive care unit. They're getting medications to support their blood pressure, and the family says still, please resuscitate this patient. We're not going to do that now if we think that recovery is extremely unlikely. And the issue of risk to healthcare workers is not a small issue here. And safety considerations may slow resuscitation. On the other hand, COVID is not a justification to withhold CPR. We make these decisions based on best treatment and best information available. And COVID is a moving target. We're learning every day about how the disease operates. People who are triaged not to receive ventilators will be offered best treatment short of the scarce resource, as well as palliative care. And the decisions are made based on scoring criteria. They're a little different for pediatrics than for adults, but the scores allow us to make decisions about who will benefit most from the treatment. Decisions need to be transparent. They have to be explained to the patient and the family. There is a right to appeal. But the appeals are based on procedure and whether proper scoring was done, not on anything else. I'd like to point out that all of the area hospitals are going to be using a very similar protocol. So there's no shopping around. A patient can't say, well, I'm going to go to Sibley because it's a Hopkins hospital rather than Washington Hospital Center because it's a MedStar hospital. I mean, there's not any shopping around. All of the area health systems have agreed to very similar protocols like this. And we know ethically also that there's going to be a lot of moral distress for healthcare workers, for families, for everyone involved. And our hospital at GW, and I know other hospitals as well, are doing programming, having counseling and support groups, and doing everything they can to support healthcare workers during this difficult time. And I think that might be my last slide. So now
Sure.
I'm gonna stop now, and we can come back and talk about those two cases after.
Yeah.
Thank you.
Thank you very much, Dr. Roth. Thank you very much for actually showing us. And for those of you who are on the phone, we'll make sure that the webinar is recorded, and you can then look at the slides that Dr. Roche presented later on. But just to let you know that she did use slides. And I very much appreciated your positioning both the cases, the 89-year-old as well as the 55-year-old side by side, and for you to raise some of the issues that pertain to ethics and some of the clinical decision-making in the real world, which is exactly what we need. Folks, if you have questions, if you have comments, please put them on the chat board. Use the all participants directive that's about halfway through in your options when you want to make a comment on the chat board. Click all participants and then put your comments in there. I'm going to make sure, and I'm requesting my colleagues Michelle and Hina to alert me as well. I'm so delighted now to hand over to Professor Melissa Goldstein. She is a professor here in the Wilkin Institute School of Public Health at George Washington University, has been involved in the field of ethics and legal issues for many, many years, has been teaching on these issues, including health policy. And I'd like her to reflect a little bit on some of the clinical ethics work that she's been supporting over the past few years. Over to you, Melissa.
Thanks so much, Dr. Hyder, and thanks to Dr. Roth and Vanessa. I really appreciate it. I have a few items that that made me think about during your presentations that I wanted to raise because these are really fascinating questions and made me think a lot about other questions that I've heard going around really in the country in these decisions. So the first one that I wanted to talk about is Dr. Madrigal raised with the pediatric cases, the issue of where do we discharge children, and of course that's the pediatric population, which generally is thought to be under 18, but then in earlier discussions with Dr. Madrigal, I believe the hospital might be treating everyone up to age 30, and I'd like to talk to her a little bit about that decision because it's very interesting because it's a different population than children's might actually deal with. So when there are kids with nowhere to go, where do they normally get discharged to? So social services, they're put in foster care, and now we're in the situation, and we might also be in those situations, keeping the kids in the hospital might actually expose them to additional risks. So keeping them in the hospital for a longer period of time than they need to is not necessarily a good choice. And then, of course, there's always the issue of homeless children. And I'm wondering right now what is happening in that regard. So homeless children and adolescents and young adults, how are we treating them in the era of COVID? And then Dr. Roth raised a lot of issues as well. First of all, when she was talking about the principle, so thinking about the principle of beneficence, so the idea of the duty to do good, the duty for beneficence, Dr. Roth talked about it as a benefit to patients. We need to benefit patients. So when we typically talk about ethical principles, we also mention the idea of respect for persons, the idea of autonomy, making decisions for ourselves. And the idea of beneficence actually includes the idea of autonomy. So treating patients for their own benefit also includes honoring their respect for persons. So I'm wondering if we could talk a little bit more about, is it different when we're talking about COVID? Are the principles themselves different when we're in a new scenario, a new emergency scenario, whether it's this particular emergency or perhaps Katrina, for example? Or is it the application of all of the principles differ because of the contextual scenario? In ethics, we always talk about how much facts matter to any particular determination. And obviously our facts now are different than they were in our era 6 months ago. Another example of this would be the application of CPR. Would we, under normal circumstances, actually perform CPR if requested by a surrogate or an advance directive, if a patient requested in advance, if the physicians think that it doesn't provide any benefit? So if it is requested, is it okay for us to perform it, or is it not okay in that situation at all, so that parallel is not okay in the new world of COVID? I also am thinking about the role of surrogates. So in the world of ethics committees before, we had a lot of discussions about choice of surrogates, whether someone's a proper surrogate, disagreement among family members. We would also, many times, if we can't determine who the proper surrogate is, go for guardianship hearings. So I'm wondering, how is that different now in clinical ethics decisions? What about when there are disagreements between what the patients want and what the treatment team thinks is best? Perhaps a treatment team might think a particular treatment for COVID is best, but the patients might disagree. These issues have come up a lot when we're talking about the different treatments that are not yet proven from a research standpoint, but physicians in various hospitals are using them. What if the patients don't agree? What if the patients do agree? What if there's a disagreement between the team and the patients? Also, what about when the treatment team disagrees with the decisions made with surrogates? How are those ironed out in this world? Is there even time? And finally, the idea of capacity determinations. In the ethics committee, most of our issues, I would say, most of our consultations involve something to do with capacity determinations by physicians. And they are often made by all physicians, but then when there were questions, we would involve psychiatry. Are there times for those decisions now? What is happening with capacity determinations? So these are just some additional questions that I wanted to highlight, but I'll leave it back up to the experts to go over our cases and maybe pull in some of these issues.
Great. Thank you very much, Dr. Goldstein. I think you've raised a wonderful plethora of issues, and I'm sure we don't have enough time to address all of them. Yeah. But I think this whole notion of operationalizing respect for persons in COVID, your thoughts about CPR and resuscitation around it, the issue of surrogate making, and including capacity determination are extremely important. So what I want to do now is to throw it open for discussion amongst our attendees, and then I will come back and ask you to respond. I'm going to take one or two.
Okay, I would love to respond, but let's take some questions first.
Yeah. And then I'll make sure that each one of you has a closing comment period before we end the webinar. Because I do want to make sure that you get a sense of how our audience is hearing and responding to this. This is really important. So one of the questions that I have, and I'll maybe take two at a time, is on the issue of off-label usage, right? So off-label use of drugs. Are there hospitals, for example, the GW hospitals or Children's Hospital, are they participating in clinical trials? So I'd like you to respond to that, and let me then just take one more issue, and then I'll go around and request you to respond to that. And one of the comments that I received was around whether age and functional status should affect decision-making in the context at this stage in time. And Danielle posed that question, so I posed the first question. So Dr. Roach, do you want to start? And then I'll go.
So you have two issues, two separate questions here, as I understand it. In terms of untested therapies, clinical trials, GW Hospital is participating in creating clinical trials as well. I think we've had a lot of panic, including from our political leadership during this emergency time, about various kinds of untried and untested treatments. And there's been, every day the internet's full of rumors about medications. One thing is, I think it's an ethical imperative in a time of emergency to keep a cool head, to follow our principles, not to betray things that we already adhere to, which is to use best evidence, to not use untested therapies without a scientific basis and without tracking. So it's unscientific to run around chasing an anti-malarial drug that has nothing to do with a different kind of parasite. I mean, there's no sense to it except that the internet is full of rumors which are then repeated by people in authority. So we are participating in trials. We're learning every day about treatments that are best treatments. For example, although we are talking about allocation of scarce ventilators, it looks like a lot of people initially were put on ventilators who didn't need to be put on ventilators, and that people recuperate whether or not they're on ventilators. So we're learning quite a lot. I think it's scientifically and ethically incumbent on us to proceed in a scientific and rational way. The other question that you asked about, you remind me what the second issue was? I can't hear you.
What is the role that age and functional status play in certain ethics decisions?
So all persons should be treated equally, but when you get, and we don't discriminate, and we try not to discriminate against people with disabilities. This is a terrible minefield. You know, there are people out there who are ventilator dependent, disabled people, and they are afraid to go to the hospital because they're afraid someone will take away their ventilator as being less worthy. So age itself, it was a discriminator in Italy. They didn't give ventilators to anybody over 65. We don't think about it. I don't think about it as age. I don't think functional ability. Let me just go into functional ability for a minute. The scoring systems for prognosis include functional ability, not in a discriminatory way, but as a measure of somebody's capacity to understand their illness, their treatment, and be able to cooperate and be able to recover. So disability, somebody who's already bedbound, who doesn't have muscle strength, is not going to be able to overcome this illness. We know that. But age itself, I don't think, should be a discriminator. The one place where, and Professor Goldstein might want to talk about this, I mean, there is this issue, it's a terrible thing, and I was deliberately provocative about CPR and about the ventilators, but what if you have two equal persons, two people whose scores come out equal? What do? You have one ventilator and two people. Do you flip a coin? Is that more rational than saying somebody was a first responder and should be entitled to preference, or someone is younger and should be entitled to more fair innings? The argument about age is not about discriminating against older people.
Sure.
Every 70-year-old or 90-year-old is not the same. It's about fair innings and in a tie. That's all. In Italy, they had a tie, I'm afraid. They had to break the tie with some rules. Sorry. Go on.
Thank you very much, Dr. Roche. Dr. Madrigal, do you want to come in on a couple of these two questions?
Sure, I'd be happy to. I know for a fact that Children's National is participating in a lot of these research endeavors as well. One of the one of the things that we've been doing as well is the COVID convalescence plasma donation. So our blood bank has been really heavily involved in that and kind of reached out to us actually for kind of appropriate engagement with the employees that have tested positive already, and how do you do that, and how do you kind of how do you do that in an ethical way? But we're also involved, as I understand, in a number of other things. I mean, interestingly, in pediatrics, we often use medicines off-label. There is certainly attempts to do everything with as much evidence and research base as possible, but just by the nature of pediatrics, there is not as much volume. So sometimes we do extrapolate adult data to children, even though it's not FDA approved. So I think, you know, we have a number of kind of team members, especially our infectious disease colleagues and other folks throughout the organization that look into as much evidence as is currently out there. And it's such a shifting environment. Things are changing constantly. Even just yesterday, there was discussions about children being at risk for a Kawasaki-like picture after either being, I mean, some are still testing positive for COVID, but presumably may have tested in the past. And so, you know, there's still a lot that we understand. I mean, even just in the last couple of weeks, we went from doing prophylactic, to be kind of standard of care prophylactic DVT prevention with Lovenox to now kind of therapeutic dosing of heparin to prevent kind of strokes and clots and things. So, I mean, I think, you know, there is a lot. I completely agree with my colleagues. There's so much out there, and it's hard to ascertain what's real and what's anecdotal, and kind of what's going to turn out to be helpful. But I think that, you know, a lot of people are using their best minds forward and trying to get those things. And then to kind of look at age and functional status, I mean, pediatrics is a beneficiary in the typical kind of age categorization. The potential life years lived is something obviously that PEDS qualifies for. I mean, functional status is a big deal because many of our populations, particularly, are like easily a third of our typical admissions within the hospital anytime have chronic illness or chronically critically ill, and I mean, a number of different ways of categorizing that. And that's concerning on how folks might use that as a determination for whether or not they should receive therapies. And so I think we share the same similar issues that Dr. Roth sounded concerned about.
So Dr. Goldstein, just to come in quickly on that, any guidance to provide here in terms of these two issues?
I would say, well, I'll fall back to the guidelines that various people are thinking about. So Dr. Roth raised the issue of Italy, and in Italy they were using age as a determining factor. And actually, in many international contexts, age is often used. We have not generally used age as a rationing determination in this particular country. We've used it more as a, indicator of function, right? Function, what it's going to mean. But that is not uniform around the world, which is something, our way is not necessarily the right way, but we have shied against it. And then the off-label uses of drugs is very, very common, I would say, and many medical practices. Generally, however, those are approved drugs, right? So they're not, they're approved for something and then they're used in a different manner. They're not purely experimental, and sometimes even compassionate usage of drugs, right, which is experimental, are used and are approved by the FDA or the right to try laws, but those are much farther down the line in terms of being tested for safety and efficacy when they are approved for compassionate use than just typically, than using anti-malaria drugs that can have very serious side effects or worse, right? So in those two areas, I definitely agree with the two doctors. They raise issues of justice issues, and I see in the questions there was also a question about antibody testing. I also wanted to talk about the idea of justice issues. So those people have been sheltering at home very, I would say, almost religiously since the very beginning. People with different chronic diseases, people with the wealth who can afford to shelter at home, right, have not been affected. And if we start having antibody tests in order to do things like go back to the work, go to the movie, go get your hair done, go do anything, if we start having antibody tests, we are creating almost another way to discriminate in society. So you're going to have all of the people who have been very, very careful or disabled or with serious chronic illnesses or serious comorbidities, and a lot of people that are over the age of 60 who have been very, very careful as well, who don't have antibodies because they haven't been exposed because of their behavior, who are then not allowed back into the functioning normal society. And we want to try to guard against that from a discrimination. We don't want to exacerbate what we've already, what we already face as a society.
No, that's a great point. Thank you for adding that, and thank you for covering another chat board comment. I think you're raising justice issues, particularly in today's world, particularly here in the U.S., is just incredibly important. But and as you said, the potential for discrimination around that is also allied to the access to all of these testing that different people have differently. I want to go to two comments, and maybe Dr. Madrigal, I'd like you to quickly respond. Amanda is asking around, what do you do when you need to send COVID-positive kids back into foster homes? What is the implication of that? And a second related question comes from Tony Yang, who's really concerned that because of COVID, kids are not being immunized. People are not going to immunization centers, to the primary care facilities, or to hospitals. And so does this mean that there would be some potential negative impact beyond the COVID-specific impacts that we're having? So as a pediatrician or as somebody working in pediatric critical care, would you like to comment on that first?
Sure. So and there were lots of good questions from Dr. Goldstein earlier, or Melissa Goldstein, that I'll try to kind of comment on as well. Let me work backwards. So immunization, I think everybody's very concerned about it. Even parents that don't have kind of concerns about immunization might have access issues. Their pediatrician's office might be closed, or hours are extremely restricted, or they're worried about going, and they're worried about, and I think everyone is worried about seeing pockets of disease come up. And in terms of kind of justice issues, I think people are very concerned also about those pockets emerging in areas of more poverty in countries where access to immunizations is difficult to begin with, where those healthcare providers that normally go out into the communities and give those immunizations are not able to do so. So I echo that. I'm very concerned. I think in general, pediatric practices are at risk for closing right now. So that's a big issue. Tell me again the one right before immunizations, the
foster kids. So releasing.
I think. Well, let me comment on that briefly and then add to it. So I'm not an expert in the foster situation, but I do know that there's some very similar concerns about sending those children back out into the communities, similar to the adults, and kind of not knowing what to do with them. I know for sure that it's very difficult to get new families online to foster children, and they are really having trouble finding kind of new places for them to go. I will add that this becomes increasingly problematic with non-accidental trauma, so children that have had injuries in their home, presumably by their caretakers. And what we're seeing actually is an uptick in that, unfortunately, and it's unclear if it's because of the proximity of being at home more, or financial difficulties, or all kind of these multifactorial things. So we are seeing an increased number of children show up at the hospital, and it's imagined that actually that's just the tip of the iceberg, and it's much more concerning underneath, because the typical people that are the sounding alarms, the kind of the first responders are usually the schools, And with the schools being closed, we're actually not getting, I think, a full picture of how much that's happening. And so then you get a new child that's been identified, and you can't send them back to their caretaker until that's fully kind of addressed and looked into, and you can't send them back to the community because the foster care situation is backed up and problematic. So it's very, very concerning. Also, to briefly kind of answer some of Melissa's questions, you've asked questions about kind of us taking care of young adults kind of up to 30 years of age, and I think that I share with you concerns about that. There's been a lot of kind of ethical dilemmas. Like most of the people in our hospital, with some few exceptions, are exclusively pediatric trained. The nurses are mostly exclusively pediatric trained, and so kind of taking care of these individuals presents a whole host of ethical dilemmas. But in the same token, I think that the hospital kind of stepped up to the plate and said, we have ventilators, we have space, we have capacity. If you don't, reach out to us. And so I think in this particular situation, Doctors Hospital, which has had a lot of, I think the brunt in our local community in Prince George's County was at capacity. And so they had, so we were able to kind of relieve in that sense. But it brings up all hosts of issues.
Sure.
In terms of kind of caring for them. And I think that our organization has done the best they can. They've put in folks that have adult training to kind of use as consults. And I should say that it is not out of the realm of possibility. We do sometimes, children that are within our organization for a long period of time often stay there, even if they have kind of gone beyond the area of majority. So that's not an unheard of thing. It's just, it gets more tricky as we get more.
Well, thank you very much for those. I think those were very important reflections. Dr. Roth, I want to bring you in on two comments and see what you have, because you may be advising as a senior physician in medicine. Both Amanda and Hina are concerned about the deliberation of risks to individual providers and the risk they take in serving humanity, right? So we have a duty to care, but the duty to care is being conflicted with lack of PPEs, lack of protection, lack of safety, and as Amanda demonstrated, even personal sacrifices in particular situations. How do you balance these two competing obligations? How are you advising your colleagues to do that?
Well, we clearly are confronted with a terrible dilemma here. People put themselves forward, and we expect in the social contract for there to be some reciprocity from employers, be they hospitals, from governments. We're talking about protecting EMTs, ambulance drivers, police, not only healthcare workers, but certainly healthcare workers. And we can't expect people to work and putting themselves in danger, and they also have, each of us has family responsibilities. I think one thing that is important to note is that this is a public emergency, and the states of Maryland, the District of Columbia, the state of Virginia have all declared this to be an emergency. And so different rules apply. Dr. Madrigal is talking about the discomfort of pediatricians caring for adult patients. And we have surgeons who are doing ventilator care, and they're not comfortable with it either. Actually, the District of Columbia, and I think all the other jurisdictions I've mentioned, have extended malpractice and liability protections to providers who are providing care outside of their specialties, because it's really important to be able to enlist people in the care of patients with COVID and not have people worried, that physicians or other healthcare workers worried that they're practicing outside the scope of their competence. I'm sure they're doing this at Children's. I know we're doing this at GW, that we have supervisors for those physicians who have the expertise that the people practicing outside of their specialty may lack, available to them, trying to support them. But we do have a social contract, we do have some reciprocity, and we have an obligation to support our healthcare workers. And in response to, if I may now respond to what Professor Goldstein said about putting values like autonomy at a lower rung than we are accustomed to. Our American and British systems actually value autonomy a lot more in the ethical schema than many other parts of the world. But be that as it may, we are really in a battlefield situation. There's no obligation, for example, for an oncologist to treat somebody with refractory leukemia with some untested or dangerous drug that won't help the patient. Physicians have never been obligated to provide treatments that are not going to help, and because the patient or the surrogate asks for, please, another round of chemo, can't you try this? Maybe we can extrapolate that. We've never been in a position where we had to do what patients wanted that way. But today we don't have time. The people can pass from being able to express their wishes to being unable to talk and unable to oxygenate within minutes and parts of hours. So emergency powers come with a responsibility. I think surrogates and patients will regain their autonomy as the emergency lifts. But part of the state powers that have been granted have to do with the fact that we are changing prioritization right now because of the demands of the illness. It's an uncomfortable position to find ourselves in.
I think that's an excellent point, Dr. Roth. I think this notion that our context has changed, right? It's a context of a pandemic. It's a context of an emergency. Even physicians and nurses are being allowed to go without licensure in other states and practice immediately on arrival, and things that were mandated by professional societies. So Dr. Goldstein, on this basis, if you could provide a sort of a closing comment as well around some of the issues that have been raised, but also to Amanda's last point, which is discussing, I'm sorry, not Amanda, but also discussing Angela's last point about, if you are a healthcare provider and your colleague is being treated for COVID, or you know that your colleague is positive, how do you react? What is your sense reacting to that? So, Melissa, over to you for a response and also your closing comment.
I actually heard an NPR story this morning about how mental health challenges have always been present in various professions, and of course in the health caregivers as well. But that right now the stresses are incredibly difficult, and really COVID is exposing how poor our mental health infrastructure in the country is, and how the calls into mental health hotlines or suicide hotlines have ridiculously escalated, right? And there's actually a story in the New York Times this morning about an ER physician from New York who committed suicide recently, and really just highlighting all of this. So what is it? What can I imagine it brings up? And the doctors obviously have more to say about this. Is like it's both guilt and it's concern and it's wanting to help, because these are people that always want to help. That's why they went into it to begin with. But then fear for their own families, ability to go home. Can they actually go home? Are they going to infect their own loved ones? Which doctors actually should still be involved in treating? What about doctors who are of one age, whatever that age is, or have their own comorbidities, right? Like what do we sideline them, or it's an all hands on deck issue, like in New York, where people they were importing people from other states, retired doctors from other states, things like that. So the range of emotions and psychological issues that caregivers are actually dealing with now is just amazing. But then the fallout, if we ever reach normalcy again, whatever that looks like, this is going to be PTSD, specialized PTSD for many, many, many years to come, for generations.
No, thank you very much, Melissa. I think that was absolutely spot on. And I think that's an unfortunate but very appropriate way to start winding down, because we have only 1 minute left. And I want to use that minute simply to emphasize that we are, as you saw in the comments and the reflections provided by Drs. Roth, Madrigal, and Goldstein, the opportunity for a plethora of ethics issues, some of which have existed with acuity even before COVID-19, to become even more relevant. Others that may have been discussed in a very general context have become very acute because the context has changed, that of a pandemic, that of an emergency. We, of course, today have not been able to touch upon a bunch of other issues around clinical ethics, some of which were very well outlined in all the three presentations. I do want to thank all three of my colleagues for coming to this webinar, for sharing your thoughts. I know you didn't get all of the time to talk about many of the other things that you wanted to. And I want to thank all the participants for being here, for being ready to listen to the expertise that was available, but also to generate these very important questions that you've put up on the board, and many others. Please stay tuned. In about 2 weeks, on the week of the 11th of May, we'll have our next webinar that will be focusing on resource allocation in the times of COVID. We'll have a set of speakers for that. And again, we'll be hoping that many of you join. Stay tuned, because we are hoping to put up a website for this and an email where you can send in your suggestions for topics if you want us to cover, or for people that you think around the world who may be interested. And increasingly, I'm very hopeful that our colleagues from around the world will actually be tuning in to this webinar as well. I see a few already today from other countries. So thanks to all of you for participating. It was wonderful to raise some of these issues. Thanks to my colleagues for being there as experts, and see you all in another 2 weeks. Thank you very much. Bye-bye.
Thank you so much.